introducing the panelists for this session. So we organized, as we call it, Roundtable session about cultural differences / spirituality. Also, again, quite a broad topic, and obviously an hour is never enough, but I hope we can have a very interesting and discussion we can all learn from. We invited some people as panelists to join this session, and I would like to ask them all to introduce themselves shortly, and then we can start. So maybe I think everyone is here. I can start with Marjolein Broeren. She is one of the people I invited myself personally. I know her through my work here in the Netherlands in the Maxima Center. Maybe Marjolein, you can introduce yourself, please.
Yes, good afternoon, everyone. I hope
I think you're still muted, or at least I can't hear you.
I can hear.
Okay.
Yeah, well, I can hear you.
Yeah.
You can hear me? Maybe.
Yes, we can hear you.
Yes. Is this better?
Yeah.
It's better.
Yeah, we can hear you.
Okay, thank you. Then I will start. I'm Marjolein, and I'm a patient expert. My daughter passed away 9 years ago. She died of a brainstem tumor. And since then, I use my experience and experiences of others to improve pediatric palliative care. I'm involved in the association Childhood Cancer in the Netherlands, as you can see in my background. And also I work for the Princess Maxima Center, because I also work as a communications advisor, teacher, and moderator in pediatric palliative care. And I'm studying, doing my master's on spiritual care to become, hopefully, a spiritual counselor in the future. I'm looking forward to this discussion with you.
Yes, great to have you here, Marjolein. Thank you so much for joining us. I think it's very valuable for us that we not only have healthcare workers here today and tomorrow during the course, but also bereaved parents and people from all other aspects from palliative care to share their thoughts and experiences with us. Then maybe, I'm not sure if Maxime Aubret, I'm not sure if I pronounce your name well, is present already. He
yes,
was
I am.
invited. Thank you very much.
And you
Welcome.
pronounce it correctly. Thank you. No problem. So yeah, my name is Maxime Aubret. I'm also a patient expert. I'm based in Belgium, and so I'm doing on a voluntary basis a patient expert role for Kick Cancer Association. And my daughter passed away in 2023. She had a rhabdoid tumor, and I was asked by Kick Cancer to join here. So happy to bring my insight, if I can, the best I can.
Yes, thank you so much also for you to join us, for your time and to be open to this, to share with all of us today. Then we have Elisha Waldman. I think he is present. Please, if you want to introduce yourself.
Hi, I'll try to do the very short version. My name is Elisha Waldman. I'll only include relevant things. My first degree in the United States was in religious studies. Then I became a physician, became a pediatric oncologist, practiced in both the US and in Israel. Then I went on for advanced training, formal fellowship training in hospice and palliative medicine. And for the last 14 years, my career has focused solely on hospice and palliative medicine. I most recently was the division head for palliative care at Lurie Children's in Chicago, and I was on the board of the American Academy of Hospice and Palliative Medicine. And now for 18 months, I've been on the team here at Great Ormond Street in London. And spirituality and cultural, well, the topic of this has actually been sort of the through line of my career.
Well, great. That sounds like also a perfect person to have here as a panelist today. Thank you very much for joining us. And then I would like to ask Iris Fried. I also see her online to introduce herself.
Hi. So, can you see me? Because I can't see myself. Okay, anyway. So my name is Iris Fried. I'm a pediatric oncologist practicing in Israel, in Shaare Zedek Medical Center. And I also lead the pediatric palliative care service in Shaare Zedek, collaborating with both patients from the highly diverse community in Jerusalem that calls for many times the question of spirituality in a multitude of communities, and also collaborating with friends from East Jerusalem. This is why I'm so happy to have here both Elisha, who we worked together in the past, as well as Rami from East Jerusalem, and as well as I'm very happy to see here patient experts, which is really one of the most important parts here.
Yes, I agree. Thank you very much. And then last but not least, Rami Zaram, if I pronounce your name correctly. I saw
Rami
you.
Zahran.
Yeah,
That's
Rami,
good.
yes. Please
Uh,
introduce yourself.
Good afternoon. So I am Rami Zahran. I am a pediatric palliative care physician. I work in an Arab hospital in East Jerusalem called Augusta Victoria Hospital. And I've completed recent training with Dr. Iris Fried in Shaare Zedek in the field of pediatric palliative care. I come from a pediatric oncology background, so we have a lot of palliative care going on, and hopefully I can bring some diversity into the discussion now, hopefully.
Yes, thank you so much. Maybe Adi, you want to take it from here and share the slides you had? I can't hear you yet.
The slides are being shared.
Oh, I can't see it yet. Sorry. My fault. Yes.
Can you hear me now? No. The connection is not so good, Adi. Now can you hear me? No?
Sounds
Yeah?
a bit better.
Okay,
Yes.
sorry.
It's
Yes, we
better.
can.
I had multiple technical issues, but hopefully now it will be better. So just introducing myself, I'm Adi Nitzan Lucas. I'm a pediatric oncologist working currently in Hadassah Medical Center in Jerusalem, Israel. And I used to work 2 years in the Hospital for Sick Kids in Toronto. And thank you all for joining us. And again, sorry and apologies for all the technical issues that I had. Okay, so we wanted to share a few words with you about spirituality and then just ask you questions and see what you are doing all over the world in the different places, different cultures. So just let's start. So this is the definition of spirituality from the European Association for Palliative Care. This is the dynamic dimension of human life that relates to way persons, whether it's individual or the community, experience or seek meaning, purpose and transcendence, and the way they connected to the moment, to self, to others, to nature, and to the significance of the scared. Okay, so question number one for all of you. Role of spirituality. How do spiritual and cultural beliefs influence families on the families' decision-making processes in pediatric palliative care? So you can just start the way you want. Maybe Rami, I can see your microphone is open.
Okay, I can start with that. So just to say a few words, so I'm an Arab, and I'm a Muslim, and probably I will start with because most of my work is with Arab patients, and I would say, and Muslims as well, like the majority of the cases that we have. We have some Christians, and recently had the chance to actually work in a multi-cultural hospital, which is Sharet Zedek. But if I start in Arab Muslim communities, I would say that generally disease is considered as as part of God's plan for us. That's how it's seen, and it's perceived as generally as a test of faith. And I think if we look at it from this perspective, we see that for people from such background, it can really help accept disease and treatment, and even the failure of treatment and death. For example, in Islamic teachings, there is part of the teachings is that God created disease and created cure. So that's one way to look at it, because it does affect how families, how patients and their families uh, make decisions related to their disease and to the treatment. If I were to look at it from a different non-Muslim point of view, or non-religious point of view, some people look at disease as karma, as it's fate's payback for one's wrongdoing. And if in this sense, sometimes it gets harder to understand such some decisions which are made by the patient or their families, because you actually have to relate to the person's experience themselves. And I believe also another thing that I want to talk about, which is certain families, certain communities, or cultures, we have to distinguish between a collective decision making and a patriarchal decision making in certain communities, which is the oldest, most respected male figure generally. That's how it's done in some places, versus the small family decision making. So there are lots of points to talk about in this sense. And we have to address it on a case-by-case basis. You cannot just look at it as a whole and apply it to all the cases. But I think that before we attempt to understand the decisions that are made by the patients and their families, we actually have to look at their environment, their culture, their religion or lack of, and everything related to them. It helps us as healthcare providers establish connection with these people, and provide them with the best possible scenarios so that they can make an educated, most suitable decision making related to their treatment or to their disease. That's what I have so far.
Thank you, Rami. Really insightful and helpful to hear your story and your view on it. I was thinking maybe, Marjolein, can I invite you to share your thoughts on how spiritual beliefs or behavior influenced you? Because we were talking as a prepared meeting, we were talking about that's not for everyone. Spirituality has to do with religion. It's broader than that. So also if you don't have a religion, you can be very spiritual. Can you maybe share your thoughts on that?
Yes, of course, and thank you. Well, I'm also from the Netherlands, and I think that in the Netherlands, and when I speak for myself, that religion, that a lot of people are not religious, and they see when their child is diagnosed with cancer or with a palliative form of cancer, that people think that's a lot of bad luck. So I think that the most parents and also myself try to search within themselves which beliefs are important at the moment that they have to make important decisions. We had to make the choice, the decision whether we wanted to give Maxine, our daughter, a life-prolonging radiation that she had to undergo 6 weeks long under general anesthesia. And as young as she was, well, it was a very difficult decision to make because my husband, he thought, well, we do not have to do that because she had to go under general anesthesia, and it was a very long treatment for her. And as young as she was, well, we let Maxine take the lead in her own disease process. So we looked at the world through her eyes, and then we saw that she was not concerned with the future, but with enjoying every day. That is why we choose not to treat her and therefore not to prolong her life. We want to add life to her days instead of adding days to her life. And as difficult as it was, this way we could still create beautiful and loving memories together. So that was our belief when we had to make this important decision.
Thank you. That's very impressive and I guess also insightful story to share here. I'm not sure if any of the panelists or participants, I invite everyone who wants to participate in the discussion to please join. Anyone has any comments? Iris, maybe I think you...
Maybe
Yes.
I can.
Oh, sorry.
No. Okay, I will go. So I'm also based in Belgium. I think the cultural, even if it's not Netherlands, is a bit close to the Netherlands. So myself, I'm not religious. My wife is Christian. And I recognize myself a lot into what Marjolien just said. Like, I'm not sure it was really a choice at the end for my case, because we were watching our daughter suffering too much from pain during the treatment. And so at the end, we were like, okay, if it's not working, it's not working. And we prefer to not see her feeling pain and just enjoying the days and adding life in the days. Really, it was one of our also leitmotiv in our day-to-day life, in fact. So it resonates a lot, and I just wanted to share my insight also to say that.
I just want to say, since Jerusalem is a very religious city, but even in Jerusalem, you can differentiate between religion and spirituality, where religion is very often the way, the actual things you do during your daily life to express the ideas you live by. But you don't have to use these actual things you do, these habits, to have core values or things you live by or values you live by. And I think spirituality is actually the framework through which you understand your reality. Where do you want to take your life from here? What are your core values? And very often these situations, end of life or complicated decision making for your child, is a situation where you face the understandings that these are the things that are most important for me, and these are the things that I want to live now and in the future. And this is the main thing that spirituality holds for us. It's something to rely on.
Iris. Alicia, do you want to add something?
Yeah, I mean, I'll add a word. I appreciate all the answers so far. I think it's a very tricky question, and I appreciate the way people have tackled it, right? Because there's a narrow way to read this question, and a broader way. And I think we're all thinking about it appropriately in the broader way. What I mean by that is, and there have been studies on this in the States, you know, if you allow people to define spirituality in a very narrow sense, it's very easy to say it's not meaningful, or it doesn't guide me, or, you know, I'm spiritual but not religious. But when you define it in the much broader sense, as Iris just beautifully put it, you know, right? It's how you live your day. It's the things that give your day meaning. To me, it's not just how does it influence decision making. To me, it's the center of the story. I mean, when I started in medicine, even in just oncology, I was always very interested in religion and spirituality because of my first degree. And I always had the sense that I was interested in like it was my own little subtopic. I was interested in something off on the side in its own silo. And it's really only been the last 14 years or so since I've been fully engaged in palliative care that I've realized that that's backwards, right? That spirituality writ large, the broader sense, it isn't just something that you should get to later in a conversation. It's the front door into the conversation, right? This is the stuff that defines, as Ira said, how people go through their days, how people think about complicated decisions. And so, I mean, for me now as a palliative care provider, this issue is always part of my initial consult. Well, often it's the first part of the initial consult. Sometimes I take a little while to build up into it, but I think this is just the most critical question, right? How do you think about yourself and your family in the world, and what matters to you, right? And all the nuances around it, right? It's obviously more nuanced than just one question. So, yeah, that's a meandering way of just applauding the incorporation of this concept into how we approach patient care.
Thank you so much for sharing that, Alicia. And I completely agree. And I think, especially for healthcare workers, especially when you're starting in this field or working with children that need this type of care, it's such an insight, and it can really change your way of talking to families if you realize that, and don't start off with the medical details or where are we or what have we done, but start with getting to know this part of the family can make it easier for anyone in the room. So yeah, thank you so much. I think it's very helpful for everyone here to emphasize that.
So we can move to our second question for today. So it's about the conflict with cultural beliefs. And I would like to hear all of your experience about what are the common cultural misconceptions or biases that we as a healthcare providers can do when working with diverse populations. So to hear this from the aspect of the healthcare providers, and maybe also from the parents, and whoever want to try to answer this question.
I think I can say a few words if you want. Hello?
Yes, please, Annie, go ahead.
Okay. I don't have a long experience in palliative care, but it has been a few years that I've been training and involved in it. I mean, unlike Alicia or Dr. Alicia or Dr. Iris, and but I think when we tackle this question, in my opinion, there are first of all, in palliative care and healthcare in general, it's not like a one size fits all. It's usually tailored to every patient differently. And I think there are three aspects the three misconceptions that we as healthcare providers um, fall into. And I think the first one is stereotyping, stereotyping certain cultures or ethnicities. In my opinion, this is the biggest misconception in healthcare, that we assume that because a person is from a certain community or ethnicity or religion or any background, regardless, that we know their choice will be such and such. And I think most of us who worked in healthcare can relate to this topic, to this point in specific. And I think, in my opinion, the second misconception would be disregarding the role of the family and the role of the community. Um, we don't look at it. We look at the patient generally, and we think of the patient. Yes, recently, more and more, we're paying attention to the family, but it's actually as of recent years that uh, emphasis has been put on not treating the patient, but treating those around the patient. And I think the last misconception is assuming the literacy is the same for everyone. And of course it's not, but uh, you don't realize how many times we fall into this, that we explain certain diseases or conditions, but we don't really get to the patient or to their family enough. Uh, that's how I see it.
Rami, what do you mean with health literacy? Literacy?
Health literacy, which is that actually the people, the patient or their family, that they actually understand what's happening with their kid, or that the patient themselves, and if they're old enough that they understand. We assume that everyone knows what a malignant condition is, and you'll be surprised that there are people who don't, and it needs to be explained more and more. We assume that if we say cancer, that people know it, but trust me, there are people who don't, they don't see it the way we expect, and I think that's the misconception I'm talking about. Um, there are people in this world who, I mean, that we're all different. We're all different, but when you say cancer, for example, when you say metabolic disease, when you say a genetic disease, um, people don't understand sometimes what it is or what it implicates. And we assume if they shake their head to us when we're talking to them that they understand. And I think that's what health literacy is. We assume that they understand, but most of the time, a lot of the time, we find that a lot of the information actually hasn't reached them. So I think that's what these are the misconceptions that we have to focus on as healthcare providers.
Yes, I agree to that. I think there's a lot about communication, of course, but I think there's also that parents cannot always fully understand, because sometimes it's too big, because it's so it's such a big news that changes your future. So sometimes it's also too big to understand, or to try to understand, because you don't want to understand sometimes. That's also, I think, important to take with us to answering this question. And what I also think it's important, due to the increased medical technical possibilities, the question arises with great regularity with which treatment we give a child another chance, and with which treatment we are prolonging suffering. And then this causes also, I think, moral stress when different parties involved interpret the situation differently. And after all, I think moral stress is the bitter feeling you experience when you cannot put your values and vision of good care into practice. And I think different interpretation can arise between parents and care providers, and also between parents or care providers themselves. So I'm also curious about the other panelists, how they think about this, well, increased medical technical possibilities.
I was thinking, I totally agree. And I was also thinking that even when a parent is able to understand, sometimes they don't want to know. Because I didn't mention when I present myself, but both my wife and I, we have a background working in a pharmaceutical company. So cancer, we know, chemotherapy, we know, and so on. But faced to the disease, we didn't have the same reaction, if I could say this way. We are not the same persons. We are able to understand the things which are explained to us. But for example, me, I was the one wanting to ask a lot of questions, to really understand all the things behind. She didn't want to know at all. And I think there are some who would like to understand, and maybe HCP might be too technical, but there are also some parents that don't want to know because it's too big to cope with.
I think sometimes, I'm really interested in what you have as parents of kids. I feel that sometimes families feel that they have to motivate us and make sure that we're still in the business of doing everything to save the child's life. And we misunderstand the meaning of what we are saying. Sometimes I find myself saying suffering to a parent, and I don't understand that some parents perceive that as a warning sign. This physician thinks that suffering is a higher value than prolongation of life. So I have to motivate her to keep finding medications. Maybe this is an Israeli thing, I'm not sure, because some families feel the decision to evaluate suffering above life. And I miss that. If I use the wrong words, then sometimes I have the understanding of the family is the opposite of what I want to achieve. Is one misunderstanding. And the second misunderstanding is sometimes, from my point of view, I miss the fact that families share with me only part of what they feel. And I very often see families share among themselves when they're in the same situation, regardless of diversity and deep differences in cultural background. If the situation is the same situation, regardless if this is a Muslim or Christian or Jewish family, you see them discussing the same core values. And that's an amazing sight to see. With me as a physician, it doesn't work at all times because of the need to motivate us as caretakers.
And what core values do you then hear, Aris?
Again, it's amazing to see an ultra-Orthodox Jewish family sitting with a Muslim family, with children at the very end of life, sharing the grief and the need to reduce suffering and the need to preserve every last minute. And sometimes, specifically in ultra-Orthodox Jewish families, I don't know if it's the same with Christian families or with non-religious families, sometimes they won't share with me the same feelings because they would feel that I might be affected by saying, okay, there's lots of suffering, then we shouldn't offer them a certain medication. I don't know if you experience that also.
Yeah, I can say
Yeah,
that I have experienced this as well. Exactly the
Yeah.
same with describing.
Yeah, me too. And I also sometimes feel, well, we talk about this in the hospital also, the role of the palliative care team and the pediatric oncologist or the main doctor of the family, that for many reasons, but also because of this reason, it's not always the best person to have conversations about this stage, like the advanced care planning conversations, but also conversations in general about how is it going, what do we want to accomplish, what is important to you as a family. That sometimes family find it difficult to talk to their pediatric oncologist about that, because that was also the person that they started with, and you often start a lot of children with the hope for cure and with options for treatment. And then in a later phase, if there are less options or no options anymore, yeah, that families sometimes also give back, like, I don't want to have that conversation, or I'm not able to share everything with my pediatric oncologist, but I did share it with a nurse from the PPC team or with someone else. I'm not sure if Maxime, you recognize this.
Yes,
I recognize them. Oh, Maxime. Okay.
go ahead. I don't know. I'm organizing it. I don't know what to
No,
add.
my daughter was pronounced Maxime, so I thought, and your name is pronounced Maxime, so I was a bit confused. But go
Oh,
ahead.
sorry about that, Marjolein.
No, I have nothing to add. I think you describe it clearly. For me, it's not that easy to, and sometimes in big hospital, you could also have multiple oncologic pediatrics compared to maybe a doctor you know better, for which it might be easier to share or to discuss. And so yes, it's not that easy to discuss that. In my specific case, I think moving to morphine, moving to palliative care was easy in the sense that it was really clear to us that we wanted to stop severe suffering. She was really young, so we were the one taking the choices. So yeah.
Thank you, Maxime.
Can I add one thought? I can't read orders here. This is amazing. I'm enjoying hearing everybody's thoughts. And Iris is making me miss working in Jerusalem. Um, and as a palliative care provider now, I get a lot of what was just being discussed. It happens very often, in particular in the intensive care unit, where families will sit down with me and my team and say, don't tell the intensivists that we're having this conversation. We don't want them to slow down or pull back on what they're doing. But at the same time, we're starting to get worried about where this is headed, right? I mean, as always, families are 2 steps ahead of where the clinicians are. So I get that a lot. I did want to call out one other specific point where sort of there are cultural conflicts that come up. It's sort of a subgroup of what Rami was discussing with the stereotyping, because I agree that if I had to say the number one problem, it's making assumptions and stereotyping, right? This is an Orthodox Jewish family, therefore they're going to choose X, or this is a Muslim family, they're going to choose Y. But the other really specific thing that comes up all the time is the talk of miracles, right? And right, the only person I can see is Alice, and I'm sure everyone's nodding, right? And I get this all the time here, especially in London. I don't know what it is about London. Families will talk about miracles, and the medical team hears that word, and it drives them crazy, right? They immediately start talking about, well, we're going to have to go to court. We're going to have to, take over and get a court order to extubate. And there's obviously not enough time here. The talk on how to deal with miracles is definitely more than an hour-long talk in and of itself. And there's tools like the Amen protocol. But I mean, the number one thing I just try at the most basic level to teach my colleagues here, and we just had 2 simultaneous cases a couple weeks ago. When a family talks about miracles, human beings, it's amazing, right? Human beings are able to simultaneously hold on to hope and belief in miracles, and also are able to hold on to, I see what's happening in front of me. And I'm not sure why clinicians have a really hard time, even though we're all human beings. Clinicians seem to have a hard time embracing that part of what makes, thank God, part of what makes us human is that we can hold both of those things at once. Because God, what would life be like if you could only choose one of those two? And we have 2 cases right now where really it was simultaneous. The families, there were acute incidents. The families both started talking about miracles. One Muslim, one Greek Orthodox Christian. The ICU staff went bananas, and through a lot of hard work, we sort of talked them through 2 weeks of the team, not the family. Let this team metabolize what's happening. Let the family metabolize what's happening, right? Let them sit with this. Let their beliefs sort of digest everything that they're seeing in front of them. And it's amazing. One mother, unprompted, looked up at us on day number 5 and said, she's a beautiful bed covered with Greek Orthodox icons. And she said, I'm still hoping and believing in a miracle. But in the back of my head, I also see what's happening here. And I know that I have to talk to you guys about what that might look like too. And it was that was unsolicited, and it was such a beautiful moment, which allowed me to say, I'm hoping for a miracle with you. I can't read the future. Man, I hope she wakes up on Monday. But I agree. I think we should have the other conversation at the same time. And one doesn't have to dispel the other. So yeah, I just want to toss the miracle word in there because I do think it comes up a lot, and it's really a big source of distress often.
Alicia, from your thoughts, do you feel that it is more easy for the families to speak about miracles with palliative care teams and not with their own primary oncology teams?
No, this was a setup. This was a perfect setup question. You're getting me to what I think is the last question on our slides. I'm going to really try to contain myself here. I'm going to shamelessly promote here. I'm part of faculty for a course, a 2-day intensive that's taught out of the George Washington Institute for Spirituality and Healthcare in Washington, D.C. We do it in person once a year and virtually once a year. And it's a 2-day intensive. The short version is teaching how to do generalist spiritual care. We know from studies that the biggest barrier to providing good spiritual care in the hospital or in any healthcare setting is clinicians feeling that they're not trained for it and they're afraid to do it and they feel like it might not be their territory. And the fact is, it is all of our job to be a spiritual generalist, not to be a spiritual specialist, right? There are spiritual specialists, chaplains and community-based leaders. But the analogy I always give, and I'm going to really do this as short as I can, the analogy I give is appendicitis, right? I'm a pediatrician, not a surgeon. It is my responsibility to know how to detect appendicitis, right? If a kid comes in with right lower quadrant pain, flatboard rigidity, fever, and elevated white count, and I don't think appendicitis, I am going to lose my license. At the same time, if I then pull out a scalpel and try to remove their appendix, I'm in even more trouble, right? So is the kid. It is all of our jobs to learn and to get comfortable with how to engage families with the basic level of talk. It's not our job to convince parents that God does or doesn't want this, or where's your kid going to go after they die, or is God punishing you? That's spiritual specialty territory. I would do more harm than good if I started, pushing parents around with God's punishing you or not punishing you. But it is my job to know how to have a basic open-ended conversation around what does this mean for you? I mean, the kid I just described, the Greek Orthodox child, where I knew there was a lot of distress in the ICU and at the bedside, my very first interaction with them, when our team met them, the only thing I asked was, I introduced palliative care, introduced our team, and the head of the bed is covered with these icons and with some holy oil. And I said, I gotta ask. I mean, I said to them that in these words, I said, I have a background in religious studies. I have an interest in spirituality. I recognize the Holy Mother in Jesus. Who are these other people? Like, would you be comfortable telling me a little bit about some of these icons and what they mean for you? That was my entire first hour meeting this family. I didn't push them any further that day, but it cemented me in their minds as someone who wanted to meet them where they were and who wanted to hear about these sorts of things. Now, I was able to do that in part because my palliative care training, I had excellent chaplains teaching me. But I don't think it's because I'm a palliative care provider. I think what I did there could be done and should be done by anyone. In other words, an ICU nurse who's sitting there at 10 o'clock at night when things are relatively quiet, that's a perfect time for that nurse to say to the family exactly what I said. Tell me about who are these figures and what does it mean for you? Or you believe in a miracle? What does that mean for you? I'm hoping to. Tell me more about it. You don't have to answer it. You don't have to solve it. It's not a problem to be solved. It's a mystery to be observed, right? And that's how we get ahead. So I love the question, Adi, because I feel like you just set me up for the how do we better incorporate spiritual care into this? The answer is everyone should do courses and get more comfortable the same way we all learn how to evaluate pain and set up a PCA. It really is no different. You can all learn how to get comfortable with this. End of speech.
Well, and thank you, Alicia, for bringing the word in miracle. You saw me nodding because I really recognize it. That what I also see happening in hospital, that healthcare workers, find it very difficult to deal with that the family believes in a miracle and actually send them the other way. We have to make more clear that we don't think that's going to happen or what we think is going to happen. And no one takes the way of tell me what that means for you, a miracle. Or we're almost afraid to say, I'm also hoping for a miracle. And we also have to have the other discussion or the other talk about if that doesn't happen. So, yeah, thank you for sharing that word and what it means.
We can't hear you, Adi.
I've got to this mute. Okay. Can you hear me now? Okay, so I think we actually touched that point. So I will move to the other question. How can we ensure that the voices of patients from underrepresented cultures, social groups can be heard and represented? How can we make sure of that?
Um, I think it's especially about asking the right questions. I think that's an important starting point. And I liked Elisa. I liked your speech about the miracles, but also about the questions you asked. I like what the symbols meant. I think it starts with questions like, what are you hoping for? What's important to you? But also questions like, what are you afraid of? What are you feeling guilty about? Because that was also very helpful to me when we had to make this decision about the treatment of Maxine. My husband wanted to spare her this treatment from the start, and I wanted to keep her with me as long as possible. And that almost felt selfish. Or would I be doing Maxine an injustice if we choose not to treat? And not treating is an unusual choice still in cancer treatment. And the spiritual counselor reassured me everything you decide for Maxine, you do out of love and is always therefore always good. And that she helped me tremendously with that. So we choose to let Maxine take us by the hand. But it started with asking me the questions so that I could think also about what's important to me, so that I could make the right decision, or that we could make the right decision in this difficult time.
I totally agree. And I think I totally agree with all those questions. And I think what may make those questions easier is also, I will say start small, but by start small, I mean observing, and like you mentioned in the example you gave, you saw those icons and you ask a simple question on those icons. And so at the start of our journey in the hospital, it was all new, and to build a trust relationship with medical care, I think it will be easier if the medical care is observing what are in the rooms, what are the small things, and start with small questions to arrive in those questions that Mariolyn just gave, which are for me, I'm recognizing and agreeing with all those questions.
Can I add something? Okay, so in my experience, in the medical field, and that it has been the nicest and most informative conversations that I have with the families of my patients are those which don't happen in the hospital, which actually happen when sometimes I go get a coffee and I meet a parent also getting a coffee, and then we talk. You know, we talk like just regular people, not a parent and a doctor. Because I think when you are in that room, in the ICU room, or in the department room, there are lots of boundaries, and it really affects how we see each other on both sides, how the parent see us and how we see them. But when we have that conversation outside over a cup of coffee, usually it really gets me as a doctor a lot of information, a lot of knowledge about the background of these people. Just like Dr. Elisha said, it creates some sort of a connection. I think that's what we do. We try to establish a connection, but um, because of working in a hospital and the stress that the hospital has in it, I think a lot of the information doesn't reach each other, and the boundaries remain intact. So in my opinion, regardless of the background, of the cultural background or ethnic background of the patients and their families, or us as physicians, I think we always have to look for ways to connect with them at a human level. I mean, we're all humans after all. I mean, one day I'm a physician, the next day I could be a parent of a sick child, and that goes for everyone. So I think that's what we should do. Try to establish a connection, because then things get easier. I'm not saying they will get easy, but they will definitely get easier. Thank you.
Steve, that
Beautiful,
the
Rami.
strong,
Thank you.
sorry, just going to say that the strongest thing we have in common with all parents is the way we look at the kids. This overcomes every possible boundary. I just received today one phone call from a mom of an ultra-Orthodox child who died a year ago, and a video of an amazing 2-year-old kid from Hebron who died 3 years ago. And we all, and the parents feel that we shared an understanding of these days that the family had gone through in the hospital, that nobody outside this close connection between physician and family has understands. So if you connect through the care for the child and the connection to the child, this is the most amazing thing possible.
I think I can add to that I feel sometimes in the hospital and in the department that it's like a bubble. Connections that were never made outside of this place are created in this bubble of the department, like between different cultures, different places over the world, different ethnicities, and the magic is there. So if we can just take it and embrace it and use it in our the way we treat those patients and their families, so we are blessed and they will be blessed, I think. Not just taking it from there.
I
Maybe
guess
I can.
maybe.
Oh,
Oh, sorry, Marjolein,
sorry.
go ahead.
I would like to add some last thought that I think we also have to embrace the uncertainty during pediatric palliative care, because I think we live in a world that more and more things are we can predict the future, or we can influence the future, but a lot of decisions are not do not have a clear answer. And what I see in my surroundings, that a lot of parents are feeling very guilty, ashamed, or that they didn't make the right decision for their child. And I think that's important, that as well as doctors and parents talk about the situation, that it's uncertain, and that parents and caregivers do their best, but that it's not their fault if a child isn't going to make it. So because I see a lot of parents suffering from the thought that they made maybe not the right decision during the treatment. So that's a point of view I would like to add as a last thought for you.
Thank you, Marjolein. I think very important and valuable, because you can never have the same experience as a parent, but moments like this with people like you and Maxime that are willing to share teach us a lot about how we can do better as healthcare workers in difficult situations like this. Wow, I have to say, I really, really enjoyed this last hour. I think it was very special and insightful. And yeah, I can just feel the energy of when you come together, speak about this and exchange experiences, how much it means. And hopefully we can all take this again in the next days and weeks and years with us. And I'd like to thank especially all the panelists for your time and for to be so open to share your experiences and your thoughts. Yeah, really nice. Thank you so much.
I
so
added
much.
in the chat. Oh, I'm sorry. I added in the chat a guideline and a toolkit that is developed in the Netherlands, and that can help you to have conversations with parents about meaning. So maybe that's helpful for you. Okay.
So much.
Thank you so much for all of you for this great conversation. I had so many other questions to ask you, but I will leave it for the next time.
Thank you so much.
Okay.